channel. We have great things there for you to follow up, including last Dr. Mary Cohen a meeting that was this week. And it was amazing about echo on ECMO. I really enjoyed that talk. So please take a look on our YouTube channel. And today we're going to wrap up our year on Congenital Heart Academy. Dr. Silverman kindly is going to talk to us about echomorphological correlations on VSD. This is going to be amazing. And what he's going to tell us is part of his online book that I'm going to type on the chat box, the link. So I strongly suggest for you guys to get this book chapter for you, because it's really helpful. I have most of his book chapters, and they're very good. So now with you, Dr. Silverman, and please type your questions on the Q&A chat box so Dr. Silverman can answer in the end of the session. Thank you, guys. Thank you, Norman.
Good morning, Grace. Okay, so let me just get the presentation on now. And can you see the presentation, ladies and gentlemen?
Yes, Norman.
Okay, so today we're going to discuss echomorphological correlations of a VSD. I've thought this is particularly appropriate to revisit because of Professor Anderson's extensive session on VSD, and also because VSD is about nearly half of all congenital heart disease that we see. The book chapter, as Grace mentioned, can be bought at www.md1world.com. And my co-authors are Professor Robert Anderson, who you've all recognized before. Bob is a most outstanding morphologist and philosopher of congenital heart disease. His associate, Diane Spicer, who's now working in St. Petersburg, Florida, has extensive associations with many archival libraries, and is a great morphologist in her own right. And my colleague, Dr. Phil Ursel, who curated the UCSF archive with me over the many years that we worked together at the University of California. Dr. Ursel is now retired. So without further ado, let's look at the ventricular septum. And this is from an excised heart, showing the right aspect of the ventricular septum and the left aspect of the ventricular septum. And you can see here the remnants of the tricuspid valve, the area of the membranous septum, which is both interventricular and atrioventricular. You can see the moderator band, or the septomarginal trabeculum, running round down here, with the little moderator band of Harvey seen over here. You can see the remnants of the tricuspid valve on the posterior limb of the septomarginal trabeculation over here, and the free tricuspid musculature here, as well as the very coarse trabeculations in the apex of the right ventricle. If we turn this heart over and we look on the left side, we can see the mitral valve and the aortic valve in fibrous continuity, the fine crisscrossing apical trabeculations, and the smooth upper border of the ventricular septum. And if we divide them, we have the heart in 4 sections. Here is the membranous septum, perfectly divided, the inlet septum at the level of those papillary muscles, the outlet septum, which is seen above here with the pulmonary, supporting the pulmonary valve, and the rest of the muscular septum, which we call trabecular septum, because trabeculum means bundles, and there are many coarse bundles here, as opposed to the left side of the heart, where we see the outlet septum, the membranous septum, the inlet septum, and the muscular septum, in this case, with fine crisscrossing apical trabeculations and a smooth upper border. Now, if we take a heart and we put it up in the or autopsy area on one of the X-ray boards, you'll see that there's transillumination because fibrous tissue allows the passage of light, whereas muscle blocks it. So here, underneath the septal leaflet of the tricuspid valve, here's the anterior leaflet, here's the septal leaflet, here's the posterior leaflet, here are those muscles with this very coarse tuberculations. You can see the membranous septum has an interventricular as well as an atrioventricular component. When we turn the heart round and look at the left side, we see the aortic root with the two fibrous triangles here between the right and non-coronary cusp. And here is the membranous septum just underneath that fibrous triangle part of the fibrous skeleton of the heart. And here is the mitral valve in fibrous continuity, both with the right coronary and non-coronary cusp. And here is the left coronary cusp as well. So these are the normal hearts. And here are the labels to show you exactly what we're looking at. The left coronary cusp, where my arrow is not labeled. And now for all of those of you who are looking at this on a smartphone, I've zoomed this up as I have in the presentation. So everything is patent and obvious and available for your revisiting. Okay, so we have left and right heart, and this is the apical four-chamber cut over here. And this simply the part of the heart that really is associated with ventricular septal defects, the outlet, the inlet, and the muscular portion of the heart. And we see the same on the left side of the heart here. Notice that the inlet and outlet are equal distances from each other. And this is a very nice example of the fine crisscrossing apical trabeculations of the left ventricle, together with the smooth upper part. So defects you'll see now are going to be in the inlet, outlet, or muscular septum. So here is this heart where we look at it on the right side, where everything is more appropriately positioned. And you can see on this cartoon on the right, the area of the tricuspid septal leaflet, the conducting tissue here, and where membranous ventricular septal defects are, and they may extend into the inlet septum, into the trabecular or muscular septum, and into the outlet septum. But they must be confined in this position. Okay? And then muscular ventricular septal defects, which can occur in any position within the muscular septum, and the doubly committed or juxta-arterial communications, which are seen between the mitral and tricuspid aortic valve. And we are going to look at all of these in sequence. But before, let's go and look at this as being an echocardiographic presentation. Let us look at the slicing of the ventricular septum in an echocardiographic cut. And this is looking at the heart from the front backwards. So this is the back section of the heart. We see the inferior buttress and the superior infolding with the position of the secundum atrial septum over here. And here's the tricuspid valve, which is in fibrous continuity with the mitral valve. And you can see this fibrous part of the skeleton that is part of the valve as we look backwards. And this is the usual way that we look at the ventricular septum when we look at it echocardiographically, noting this fibrous communication between the mitral and tricuspid valve as the central fibrous body. Now, when we look at the heart from the back forwards, the mitral valve is on this side here, and you can see the offsetting between the mitral and tricuspid valve over here, the inferior buttress, the secondary septum, and the superior infolding. And you can see the AV node artery. There's the oval fossa rim, the left and right atrium, and the ventricular septum. And I'll show you the position of the AV nodal artery, the tricuspid valve, and the mitral valve. We will not see this most of the time on echocardiography. So now we look at this in real time, and the first question that people ask is, where is the membranous septum? And here you can see the central fibrous body, the fibrous connection between the mitral and the tricuspid valve, which is part of the normal heart and relates to the embryological closure of the ventricular septum in the membranous region by the tubercles of the AV canal. And the other structures that you've seen and can recognize here: pulmonary veins, left atrium, right atrium, inferior caval vein, coronary sinus, and so on and so forth. But I want to stress the offsetting of the AV valves in this area. And as you move the scan pane forward, the mitral valve separates from the ventricular septum and interposes the aortic root in this position. And so this here is the area just underneath that right fibrous trigone that represents the membranous septum. And you can see it has an atrioventricular as well as an interventricular boundary. So this is what we do echocardiographically between the time we see the four-chamber view with its posterior muscular interventricular recess here, the interventricular recess, and we scan forward. The aortic root moves away from the heart, and we see the area of the membranous septum. And once again, the cartoons showing us the event, the possibility of muscular, doubly committed and juxta-arterial membranous defects, and the muscular defects may be in the inlet septum, in the outlet septum, or in the trabecular mass. And here is the septum marginal trabeculation. And let us also not forget here with yellow representing the intact septum, the position of the atrioventricular conducting tissue in relationship to this, which is important for the surgeons, but something that we can recognize for them. So when we discuss perimembranous ventricular septal defects, which are first and probably up there as one of the commoner defects, may extend into the inlet trabecular and outlet septums, as I've said. It may be associated with other septal defects and may have several other associated lesions such as coarctation, patent ductus, atrial septal defect, and a host of very different defects which are not discussed here, like the truncus, tetralogy, transposition, and double outlet, which are available on separate chapters in my book. Now, here is an echocardiographic cut of a patient with a perimembranous ventricular septal defect. And here you can see almost the communication underneath the tricuspid valve, the fibrous flap of membranous septum that remains, and the fibrous continuity between the tricuspid and the mitral valve, which is the hallmark of a perimembranous ventricular septal defect. And here is the specimen with its labels on, and I'll take the labels off so you can see this exquisite picture from Diane Spicer's archive. And I've matched that with an echocardiogram, both in black and white and with Doppler color flow imaging superimposed upon it. And you see here, when you see a membranous VSD, you can also see the aorta, right and left atrium, left ventricle, and right ventricle. And here are the rims of the ventricular septal defect. I've taken that off. And this is unlabeled, and this shows you the acceleration of blood that occurs within the left ventricular outflow tract. When there's a ventricular septal defect, the red cells can either go out the aorta, or as the pulmonary vascular resistance drops, comes more and more across the ventricular septal defect. So this is just an example of the location of a perimembranous VSD, and you can see here the aortic root, as you can see it here, and that is a membranous ventricular septal defect. and it's magnified. I won't mention any more about the magnification because it occurs in all of these subsequent presentations. And it is for those people who use smartphones and have a small screen to look at, so it's enlarged for them. Now here's a parasternal long axis. We saw a 4-chamber or 5-chamber view for the membranous VSD, and this heart is oriented in the long axis or the short axis on echo. And here we see this fibrous flap, which is the remnant of the membranous septum associated with the ventricular septal defect, which is oval and not circular in its presentation, looking at it from the left ventricular surface with its smooth upper border and fine apical trabeculations. And here I've oriented this in a long axis. Short axis would be exactly a cut in this direction. And of course, here are the two pictures. And here you can see this defect immediately underneath the aortic valve. The blood flow is either going out the aorta, or in this heart, there's a large left to right shunt because of decreased pulmonary vascularity. The left atrium is enlarged, much more so than the aorta, and there is the long axis cut. And here is the short axis cut, showing left and right atriums. Here, the fact that there is almost, can be seen here, fibrous continuity between the tricuspid and the aortic valve, but not the mitral valve, as that's behind us, and the muscular septum, which is seen above. So this VSD abuts the septal leaflet of the tricuspid valve, which is a very good reference for the position of the membranous septum. So here we've located the ventricular septal defect in 3 different locations. This is the same patient, as you can see from the electrocardiogram. And we can also see this, excuse me, subcostally. And here you can see the tricuspid septal leaflet. And immediately under the septal leaflet, we can see the ventricular septal defect. Here's the ventricular infundibular fold and the septum marginal trabecula, which in Van Praaghian terms is the crista supraventricularis. And this defect has a fibrous connection to the mitral valve seen through the ventricular septal defect. Now, echo cut is very precise and doesn't show these 3-dimensional views in 2 dimension, but here is the ventricular septal defect underneath the aortic root, and here is the pulmonary valve quite remote from this VSD, right ventricular outflow tract, superior cava and right atrium. And I'll take the label away there so you can see the ventricular septal defect. Here, this should be closed off, and it is not. And here is the Doppler color flow image of right ventricular flow, showing the ventricular septal defect jet extending downwards towards the diaphragmatic surface of the right ventricle. And I'll just stop that for a moment so that you can see that beautifully in the Doppler color flow signal. So there's systole, which I can't see as I'm showing it to you. So I'll let it play again, and I'll take the labels off so that you can see that. And there's the ECG. And now I'll put this away over here so that you can see the electrocardiogram showing that systolic beat again and again with the flow coming across the defect in systole. And we can look at the left ventricular aspect of ventricular septal defects. And here we can see the septal leaflet of the tricuspid valve herniating through this ventricular septal defect with the classical fibrous continuity between the septal leaflet of the tricuspid valve and the mitral valve. Here is the ventricular septal defect underneath the left aortic fibrous trigone between the right and non-coronary cusp, right over there. And here's the defect herniating through there. Let's take the pictures off and show you the raw picture. Unfortunately, it doesn't move because it comes from an autopsy specimen. And now we look at the this fibrous herniation of the tricuspid valve there as it goes through the defect. So here is a subcostal sagittal cut showing this defect herniating backwards and forwards across the defect. And I'm going to stop this for you now. And you look at the ECG on the bottom here. There's the beginning of systole. So the defect herniates in systole into the left ventricular outflow tract, which is here. Here's the aorta. So that there's elevated pressure here as this inference from why you see it here. And so there is the defect. And now we go into diastole. And in diastole, it herniates one more time into the outflow tract because the right ventricular end diastolic pressure is elevated. And there you see the motion. And here from a different patient, you can again see this herniation of the tricuspid valve. And now you see it, tricuspid valve opening with the herniation prolapsing in diastole with opening. And in systole, it moves back into the left ventricular outflow tract. So this patient has got elevated diastolic and systolic pressures, as you can see from the position on the VSD. Okay, so there's bidirectional directional jets across this, both in systole into the left ventricular, in systole into the right ventricular outflow tract, and in diastole into the left ventricular outflow tract, indicating elevated pressures on the right side of the heart. So very important information. Now, defects may be, as we've seen now, perimembranous, but here's the pulmonary trunk with attenuation of the space between the ventricular septal defect here and the pulmonary trunk over here. So this ventricular septal defect is extending into the outlet chamber over here. And now we are looking at the ventricular septal defect. I don't think it shows quite as well as on this particular plane, the herniation into the right outlet septum. But you'll need multiple planes to be able to see this. And that, I think, is the important issue about ventricular septal defects in terms of getting their geographic location, that you have to use multiple planes to make the precise recognition of where the ventricular septal defect is. Here's the pulmonary valve right over here. So we are close to the outflow septum as we see it here. So this is a large ventricular perimembranous VSD, which is extending into the outlet septum as shown over here. Now here's one with an anterior deviated outlet septum. This defect was often called the Eisenmenger's ventricular septal defect. And in fact, because of the fact that there is no subpulmonary obstruction, is the key unifying feature to differentiate this from tetralogy of Fallot. So here you can see the pulmonary trunk. Here's the ventricular septal defect. And here's this deviated outlet septum. I'll take the labels off for you. There's the deviated outlet septum. And there you see the motion, pulmonary valve, aortic valve, with this little bit of outlet septum between the two. And the outlet septum is slightly superiorly deviated, but not yet causing any obstruction. So this is, and has a little tricuspid regurgitation and an atrial shunt as well. So this is a rare defect, but shows the anterior outlet, deviated outlet septum, and is called often the Eisenmenger's VSD. Now, one of the consequences of a VSD, which exists underneath the aortic valve, is that because there's no support specifically for the right coronary artery, right coronary cusp, that the coronary cusp may herniate into the ventricular septal defect, and in doing so, may diminish the size of the shunt that you're getting. And so what happens in these patients clinically is you hear the ventricular septal defect murmur diminishing in the course of your examinations, and the presence of aortic insufficiency as this cusp no longer allows apposition appropriately to the non-coronary and left coronary cusp. And you see this acute angle here, which is also seen on the echo here. This angle is not smooth like a ball, or I like to call it like a baby's bottom, a nice brown smoothness, but has a sharp focus on it. And here's the ventricular septal defect, which looks small, but it only looks small because the defect has herniated into the cusp over here. And so here you see the presence of the ventricular septal defect and a little bit of aortic insufficiency. So VSDs are relatively easy to fix with a very excellent prognosis, but aortic insufficiency is not so wonderful a job, and it occurs throughout lifetime. And so it's better to fix these defects when you see aortic insufficiency occurring. So here you can see this. I can stop this for you in to show. There's the bend that we saw. You can do this on your smartphones if you have the application. You obviously can't do it if you're looking at the streaming video. And there's the AI, and there's the ventricular septal defect. So as we come into diastole, we see the AI. So systole and diastole, there's the AI. So I'll let it play, and I'll mag this up so that the two comparisons are there for you to see. And looking at it from a subcostal coronal cut, we can see this cusp herniating through the ventricular septal defect and into the right ventricle. Here's the pulmonary valve. The defect is obviously perimembranous. There's the posterior rim of the septum marginal trabeculation and the anterior rim supporting the pulmonary valve. Here is the anterior papillary muscle supporting the tricuspid septal leaflet. And here you can see the ventricular septal defect. Again, note the shape is not circular, and there is a herniation of the cusp into the defect. So now we can look at that on echo. And what you see is you look at it, draw a line over here between the non-coronary cusp and the right coronary cusp. And you'll see that this leaflet is actually herniating beyond that imaginary line, as you can see it here. And as yet, there is no aortic insufficiency, or maybe there is a tiny little bit of aortic insufficiency draining left to right as well, and coming off the base of this herniated cusp. So that's obviously occurring at the commissure and not through the cusp directly, obviously in 2D echo. But here you can see a perfect morphological comparison between the specimen with its herniation and the echo with the right coronary cusp herniating through the defect. Now, one of the things about the natural history of ventricular septal defects is this position of the tricuspid tissue tag, which is quite complex. And here in an operative specimen, you can see the left ventricular sucker. The sucker here is 2 millimeters. So the ventricular septal defect is about 2 millimeters and is already surrounded by a tricuspid pouch and patch of tissue, which is helping close the defect. So there is endocardial proliferation across the ventricular septal defect, as well as the tricuspid valve becoming adherent across this defect and eventually may close this ventricular septal defect. In this case, the patient got to surgery before the ventricular septal defect was closed, and on the count of the size of this defect, one has to really question whether an operation was actually warranted on the basis of this patient's symptoms or not. And here is a patient who had this disease, as you can see, but died from ischemic coronary artery disease and got a heart transplant for the ischemic coronary disease. And when we opened up, we saw this tricuspid pouch here, as well as the endocardial proliferation across this defect, which is beautifully matched with what we saw at surgery. So this patient escaped and later on in life had a heart transplant for ischemic cardiomyopathy. And here is an echocardiographic cut showing the echo planes here. And you see in this 4-chamber cut, left, right atrium, left, right ventricle. And there are these tricuspid tissue tags. And you can see proliferation across this from the endocardium, as described by Dr. Van Praag, and the walling off of this defect by the septal leaflet of the tricuspid valve. And there's no black and white image, but you can still see a little jet, a little hole, not a jet, coming out through this ventricular septal defect. And here is a specimen, again, from the Brompton archive from Professor Anderson's group, showing a 4-chamber cut. And here you can see this man also died from calcific aortic stenosis, and his heart was retained in the Brompton archive. And you can see the calcification that occurs in later life as part of a calcific aortic stenosis. Here's his left coronary artery. And here is this so-called tricuspid tissue tag, or aneurysm of the membranous septum. And you can see it's completely walled off. There's no associated ventricular septal defect, but you can still see the tendinous cords of the tricuspid valve attached to the crest of the muscular septum. So, and again, another old patient, and here, and matched with an echo of a very young patient, already showing the membranous proliferation across the endocardium of the septal defect and the walling off of the tricuspid valve, which, as you can see, is incomplete from the size of the jet. And if you would want to see the size of this ventricular septal defect, you would have to go and look at this in systole. And this is the area where the defect is at its lowest. Although the ventricular septal defect is somewhat walled over, the restriction is occurring in the tricuspid valve at the area of the vena contracta, which means the narrowest angle of a jet. And so if we look at the size of this being 1 centimeter, we have 3 or 4 millimeters, which suggests that this is an extremely restrictive ventricular septal defect. Now we've cut the heart in short axis here again. We put it back together with crazy glue. And here you can see the left ventricular outflow tract and this pouch of tissue that you saw here now attached and coming and herniating underneath the tricuspid valve into the right ventricle. And here again is the short axis cut here, again with color. You can see the tricuspid tissue tags when I take off the labels. And again, I have to, hopefully can stop this here. And there you see the tissue tags surrounding the defect in systole and walling off the defect. There we go. And there's the vena contracta there, still about 3-4 millimeters. And it drops off and as systole progresses to be even smaller. And then in diastole goes the other way. So there's still left to right shunting occurring in diastole here. Did it play for you? Okay, now one of the frequent associations of perimembranous ventricular septal defects is the presence of a subaortic fibrous shelf. And this occurs commonly with VSDs, but it also occurs more commonly when there's associated coarctation. So here's an example of a specimen that shows the position of the aortic cusp and the fibrous growth across the membranous septum of this fibrous shelf of tissue. Let's just look at this. So from left ventricular outflow tract, here's the aorta in long axis, here's the muscular septum, and across this area you can see the growth of this subaortic fibrous shelf, which also extends onto the anterior leaflet of the mitral valve. And here is an echocardiographic example showing the fibrous shelf close to the aortic valve, as well as aortic insufficiency developed as the result of the trauma of the turbulent outflow tract distorting the aortic cusps from long-term jet trauma. And of course, this is almost with the size of the VSD, an indication for surgery. So there you see the membranous, perimembranous VSD, which is small, and the fibrous nature, which is going to be progressive throughout the life of this patient, if not operated on. And lastly, we look at perimembranous ventricular septal defects with straddling valves. And here is an example of a perimembranous defect from the Anderson archive, showing the caudal leaflet of the tricuspid valve straddling across the ventricular septal defect, which is perimembranous in location, and attaching to one of the papillary muscles together with the mitral valve leaflets in the left ventricle. And of course, this becomes a problem. And the other feature with a hallmark of straddling tricuspid valve is the disassociation between the atrial and ventricular septum, a malalignment. It looks like they could never go together. And this is probably related to the anomalies that occur in the ventricular spine of His and the mesenchymal cap that occurs across the septum. Here it is fused, and you can see the tricuspid and mitral valve orifices attached separately here. And here was a muscular defect. And here is an example of such in a patient from one of my travels. And here you can see the malalignment between the septal leaflet, but between the ventricular septum and the atrial septum. This is the hallmark of straddling valves. So malalignment relates to the fact that this didn't occur at the right time. This is a large perimembranous defect extending underneath the mitral and tricuspid valve, so it has inlet extension. And you can see the septal leaflet of the tricuspid valve is crossing the ventricular septum and attached into the left ventricle. Now, that doesn't mean that this patient should have a single ventricle repair, because if the right ventricle is large enough, the surgeon can simply detach the tendinous cords and either put an Aortic cord or attach them within the right ventricle and close the ventricular septal defect, or even close the ventricular septal defect around the tricuspid valve, leaving a small orifice of tendinous cord going through there. Also note the large left superior vena cava coronary sinus connection in this patient. So once again, look at the inlet component attached across here, and also that the tricuspid valve not only is herniating through here or has an override of the ventricular septum, but the caudal attachment is to a papillary muscle arising within the right ventricle. And the last defect that occurs in this region is the so-called Gabodi defect. And this is courtesy of Dr. Carl Becker. Okay, and you can see here is an artist's drawing of this small little communication, which Frank Gabodi and his colleagues wrote up as what they called a atrioventricular defect, because the left ventricle is on the other side of this, and the defect is going into the right atrium. Now, this is a very nice picture, and here is an operative picture of such a lesion. You open this, the atrial septum ends over here. Here is the inferior buttress of the atrial septum, and here is the leaflet, the defect, lying within the base of the septal leaflet of the valve, and here's the coronary sinus. So this is clearly a LV to right atrium shunt, and here is such an example, and you can see the ventricular septal defect, and you can see this defect jetting, as looks almost like tricuspid regurgitation, but has a much higher velocity because it's coming from the left ventricle into the right atrium. And this is not a true Gabodi defect. This is the secondary type of ventricular septal defect, where there's a perimembranous VSD and associated tricuspid regurgitation going across here. This is a primary type of Gabodi defect. And I had an extensive look for a perfect example of one and was never able to find a perfect example of a primary Gabodi defect. So I put this secondary Gabodi defect down for you so that you can see the position of a left ventricular right atrial shunt. And of course, if ever you find one of these, you can always send it to me and I'll put it in this presentation for future generations of people that look at the website and my book. Now, the next big section is muscular ventricular septal defects. And it depends when you do your incidence studies, whether you find the defects in the muscular septum are larger or of a higher frequency than perimembranous VSDs. Because in utero and in the neonate, muscular defects are much higher, but they have a higher incidence of closure. Perimembranous VSDs, particularly if they are longer than 5 millimeters in the 4-chamber view, or if they are more than 0.5 of a square centimeter, have a high incidence of need requiring surgery for left to right shunt problems. Muscular VSDs have a much higher incidence of closure. So here's this diagram that demonstrates again the muscular VSDs, which can occur anywhere within the muscular septum. Of course, they don't extend into the membranous septum, so that there is an area of muscular tissue surrounding the border of these defects. And even here in the outlet septum, you may have muscular outlet defects, but they don't extend up towards finding that there is now fibrous tissue of an atrioventricular or a semilunar valve as the border of one of these defects. So the classical mid-muscular ventricular septal defect is shown in this specimen here from the Anderson archive. And you can see here is the inlet septum, the fibrous body, the mitral tricuspid fibrous continuity through the body, and the defect situated in the so-called 4-chamber cut in mid-muscular level. And we see this from the subcostal view, as you see it here. There's the perimembranous VSD. And here's the same thing from a sort of 4-chamber cut, a more 4-chamber cut, although it's a subcostal picture, and showing the position of the membranous septum with muscular inlet septum behind this defect. So this defect on echocardiogram and this particular plane is entirely surrounded by muscular tissue, as it is on the specimen. So this is therefore a muscular ventricular septal defect. And here in the short axis in this patient, you can see the ventricular septal defect. Here's the tricuspid valve. So there's muscular tissue all the way around this defect. And note again, it has this cigar shape to it, or football shape, American football or rugby football, but not the famous international football that we saw yesterday when Argentina beat France. And here you see the ventricular septal defect with the components of muscular tissue surrounding this defect all over. And you can see that the mitral and tricuspid valves can see each other through this ventricular septal defect. And there's color on this defect as well. So black and white with color superimposed upon it. And you can see this is a systolic shunt, and the color flow is low, suggesting that this defect is large and that it is probably a non-restrictive ventricular septal defect. Now, the commonest ventricular septal defects that we see in babies occur in this muscular region. Here you can see this is down at the apex, a tiny VSD, makes a big noise and a big fuss, and you find this in the babies, and many of these defects will close immediately after the neonatal infancy period is open and no surgery is required. And of course, if you do another echocardiogram and you show that these defects have gone, the mother is very, very grateful to you. So they don't require surgery often. Now, the other thing about them is when you see this in a 4-chamber view, if you get a 4-chamber view that is not truly apical, it may look like an anterior apical ventricular septal defect. Let me just see if I can show you that. Oh, I've done something wrong here. Just let me get back to that. Here we are. Yeah. Oh, I need to move on. Excuse me. Yes, I want to go back to this frame. And I want to show you that this looks like it's an apical defect. But if your echoplane is coming higher up, it still looks like a four-chamber view, but is not apical, and defects like this may actually exist underneath the pulmonary valve. And I wanted to show you another picture of that. I hope I haven't confused you with this. So this looks like an apical four-chamber view, but it may just simply be an anterior four-chamber view. And if this was the same patient, you can see this ventricular septal defect is immediately underneath the pulmonary valve. And that is something that you have to look at. So you need to get a 2 or a 3-dimensional fix from different cuts at orthogonal planes to be able to see this. And here is the ventricular inlet. Here is the wandering through the ventricular septal defect. And here is the outlet immediately underneath the pulmonary valve. And here you can see this outlet over here immediately underneath the pulmonary valve, but surrounded entirely by muscular tissue. And I've put the red dots on to show the passage of the blood through the ventricular septal defect, with the arrows indicating the inlet and the outlet of the ventricular musculature. Now, this defect that we see over here in the four-chamber, the subcostal, in the short axis views, parasternal short axis views, shows a defect that looks like it may be underneath the tricuspid septal leaflet and therefore be perimembranous. Yet when you look, you can see that there is muscular tissue all the way around this defect. The conducting axis is therefore safe. This is a tricuspid defect, but it is muscular. And we can recognize this echocardiographically as well by looking at the muscular tissue surrounding the ventricular septal defect, both high up underneath the left ventricular outflow tract and low down underneath the mitral and tricuspid valves. So we took this away, and you can see that there is muscular tissue here in real time. The ventricular septal defect is smaller. The membranous septum is intact, okay, underneath this area here. And the defect extends lower down into the muscular defect, showing the tricuspid and mitral valves seeing each other across the ventricular septal defect, as it were. And there's the outlet septum as well. So muscular trabecular septum and outlet septum immediately separating the tricuspid, the mitral from the aortic valves. So that's a muscular inlet ventricular septal defect. Now, here's another muscular inlet ventricular septal defect. Here's the septal leaflet of the tricuspid valve. Here's the coronary sinus, which is posterior, and the oval fossa, as you see it here. This is the medial tricuspid valve leaflet here, the inferior leaflet, and the septal leaflet. And you can see I put a forceps through this ventricular septal defect to show you where this is going from the left ventricular outflow tract. And these defects are rare, but they are important because the surgeon will not see this when he comes through the tricuspid valve unless he does special maneuvers on the heart. And here you can see such a lesion here at the junction of the free wall of the left ventricle with the inferior wall here. And so this defect is way, way posterior and inferior in the muscular septum. I think these are important defects. You can see that this is a big defect. The velocity is not terribly high, maybe 85 centimeters per second, without any aliasing of this defect, and that the vena contracta of this defect is large, indicating a need for surgery. There's also right ventricular hypertrophy, as you can see here, or as a result of long-standing elevated right ventricular pressure in this patient. Now, apical muscular VSDs, they're all muscle because the septal leaflets are away. The outlet is completely different, but you'll often see that the moderator band and this defect make it look on the right side as if there are multiple defects. But when you open it on the left side, it looks like a singular defect. And of course, echo does that. And you can see that how big this defect is because there is very little acceleration of flow as this VSD comes through and goes into the right ventricle. So this is an apical muscular ventricular septal defect with color flow organizing this. So these defects can be today handled quite well with devices. And of course, they're very difficult to operate on surgery because the patch has got to go all the way around over here and retain all of these things. And it requires extensive operation. Here's another example of muscular ventricular septal defects, most frequently found with the tetralogy of Fallot, not in this case, but you can see here's the anterior wall of the right ventricle. Here's the muscle of Lancisi with the septomarginal trabeculation, or the papillary muscle of the conus, as this is called. And you can see numerous multiple ventricular septal defects. And if you do subcostal coronal cut, you can see all of these defects, as I've shown with the arrows here, going across the ventricular septal defect, and they can be very difficult to repair. Now, the Swiss cheese ventricular septal defect, or multiple ventricular septal defect, is beautifully shown with this transilluminating picture of Diane Spicer with a 4-chamber cut displayed across it. And you can see I put arrows for each one, and I didn't fill them all out, of these ventricular septal defects. And if you shine a light in the specimen, they transilluminate beautifully. So let's take that off there. And here you can see, because we're only looking at various points, you've got to sweep backwards and forwards on these to see these ventricular septal defects, that this is at least 3 large VSDs in this particular axis. And there you see just the light shining through from the left ventricle through the muscular ventricular septal defects, with these multiple defects that you can see with Doppler color flow. And of course, the velocity is low because right ventricular pressure is elevated. So there's no a real Pisa acceleration of the color flow jets across the defect. And here's one with a perimembranous defect and associated muscular ventricular septal defects. Perimembranous VSD and associated muscular ventricular septal defects. And this is a 4-chamber cut. Obviously, we would do several cuts to show that. And you can see as we look and move the plane from the membranous VSD down towards the muscle, you can see all of the defects in the muscle of this ventricular septal defect as well. And my adage is usually if you find one muscular VSD, look for a second. If you find a second, look for a third, and so on, because they are frequently multiple. And they may be associated also with the spongy myocardium or hypertrabeculation, as Bob Anderson likes to call it. And some of these defects will eventually require intervention. Here's a patient that has 2 devices in 2 big muscular ventricular septal defects. Okay, this one looked like it was a little too tight for the defect, but over the course of time in this very patient, you can see the defects have collapsed, and you can see both the left ventricular and right ventricular discs of these 2 muscular devices. And you can see this was done at the time of surgery. And here's one that from an earlier area that got a muscular device placed in here, and then found another defect. And this was done with the Gore-Tex pledget. The patient also had an AV septal defect as well. And this whole thing turned out to be very difficult, but I just wanted to show you that this heart over here showed the presence of multiple ventricular devices that you can see in this specimen here. And the last defect, muscular defect, is this one, which is a traumatic VSD from a little boy who was situated in the back of the car without a seatbelt, and a head-on collision occurred, and the child smashed up against the seat and ruptured his ventricular septum, just as you see in ischemic heart disease in older patients. And here is the defect with the entry from the left ventricle and the egress from the right ventricle. And here is a patch placed on the left ventricular aspect with pledgets and covered with a pericardial patch here. So let's look at the echocardiogram. The patient survived and did well. So here is the ventricular septal defect, and you can see here the left ventricle with the open tear in the ventricle. You can see this lake of tissue that we saw here, and you can see the egress going out into the right ventricle here. Let's cut this in the long axis now and look at this one here. And this was done at transesophageal echo and shows the inlet, the lake, and the outlet into the right ventricle from this arrow here. Let's get the labels off so that you can see that. So there's a big tear in the ventricular septum. And then in the four-chamber view, we were able to get the inlet, the lake, and the outlet in one view. So we have a good idea about this defect that fortunately landed up with a success. Okay, now lastly, muscular VSDs with a posterior deviation of the outlet septum, often associated with aortic arch anomalies such as interruption or coarctation, which led Dr. Van Praag to say that in coarctation and interruption, when there's a ventricular septal defect, all the woe lies below. And here is the outlet septum, which is posteriorly deviated here, narrowing the left ventricular outflow tract. Let me take the labels off for you so that you can see that. Here's the right ventricle. Here's where the ventricular septum should be, but the posterior septum is deviated, narrowing the left ventricular outflow tract and causing trauma on the aortic valve as well. So there you see it, and we can compare this to the echo, which is easy to see, maybe clearer than the specimen. In this case, this is a muscular defect because there's no continuity between the mitral and the tricuspid valve. And here is the posterior outlet septum, which is deviated. And if we see one of these, we usually will fix the coarctation first and then come back later and do the ventricular septal defect if this is very small, or just simply put a patch across here and maybe excise this part of the outlet septum underneath the aortic valve here and close this ventricular septal defect. So these defects, I might tell you, I learned from Dr. Anderson and Spicer's presentation, may be perimembranous if there's fibrous continuity between the mitral and tricuspid valves, but in my experience, they've been largely muscular ventricular septal defects. And here's another example of one seen from the apex from Diane Spicer's beautiful specimen. And here you see the posteriorly deviated outlet septum narrowing the left ventricular outflow tract and leaving a big ventricular septal defect. And if we cut across this in short axis plane, this in a neonate with an interrupted aortic arch, you can see the muscular block between the mitral and the tricuspid valve. So this is muscle, so it's not a perimembranous VSD. And here is the posterior deviation of the outlet septum in short axis. Now, lastly, doubly committed subarterial VSDs. This one is a real problem. So here's a normal heart from Diane Spicer showing the fact that there's a freestanding subpulmonary infundibulum in the normal heart. Here is the Y of the septal band, okay, with the anterior and posterior aspect and the septum marginal trabeculation running down here. And you can see that the mitral and tricuspid valves are on a different level. In the doubly committed juxta-arterial defect, this becomes fibrous and almost disappears, allowing fibrous continuity between the mitral and tricuspid valve. And here is the VSD cradled in the arms of the septum marginal trabeculation. And this is all that is left of this little amount of tissue, which was part of the subpulmonary infundibulum. And the reason why in the normal heart you can do a Ross procedure, because it's this muscle that is taken out and have the valve supplanted into the aortic root. If you don't have a subpulmonary infundibulum, you can't do a Ross operation. So here's a beautiful example of the two, and here's an echocardiogram with an example showing the pulmonary trunk and the aortic trunk through it with fibrous continuity. And here's the ventricular septal defect seen over here beautifully. And in long axis, the thing that's key here is that the pulmonary valve leaflets and the aortic valve leaflets are in fibrous continuity. So this defect is not only subaortic, but subpulmonic, and we call this juxta-arterial or subarterial in its nature. And here is a sweep going down from above down to show this continuity. Let me take the labels off for you. There's the VSD, here's the pulmonary valve, and here's the left ventricular outflow tract. When we come up high, you can see the aortic valve. There's the aortic valve leaflets, pulmonary valve leaflets. Okay? So there's fibrous continuity, and there's no outlet septum between the two. Notice that this defect is out at about on the clock between 12 and 2, as opposed to perimembranous VSDs. Okay, and here's a subcostal one showing again this fibrous continuity between the pulmonary and tricuspid valve, pulmonary and aortic valve, I beg your pardon. Okay, and I think you can see the ventricular septal defect very beautifully. I'm going to pass on because of the passage of time. We're nearly completed with this presentation. And there you see this VSD here. Now, this is an explanation of the difference between perimembranous and doubly committed and juxta-arterial VSDs. And here is the secret, the right coronary cusp. In a perimembranous VSD, the defect is between the right and the non-coronary cusp. So the right coronary cusp is involved. So the defect here on short axis is going to be at 10 o'clock, between 9 and 11 o'clock. Perimembranous VSD. And here is a doubly committed and subarterial VSD, and its position is at 2 o'clock, 1:30 to 2 o'clock. So and this defect is situated between the left and the right coronary cusp. So it's just the coronary cusp that makes the difference. It doesn't look like a tremendous amount to you, but surgically, the perimembranous VSD is repaired through the tricuspid valve, and the doubly committed and juxta-arterial defect is repaired through either the aortic or the pulmonary trunk. Depends on surgical preference. And you can see that the defect is not supported by the pulmonary valve, has got pulmonary insufficiency as well. And of course, when you have the juxta-arterial defect, the right ventricular or the pulmonary cusp or the right coronary cusp may be enlarged and not supported, so it may herniate through here and give the appearance of, in fact, an aneurysm of the sinus of Valsalva. And here you can see the displaced herniated leaflet, which I got from the Mayo Clinic. Thank you, Mayo Clinic. And here is the VSD, which shows tremendous herniation of the cusp. And you see it just a little VSD here, but the VSD is a huge VSD. And in order to save AI here, aortic insufficiency, which is present, or keep it minimum, closing this VSD in the 17-year-old was the order of the day. The AI never goes away completely, but I think it prevents the progression. So other VSDs, we see VSDs in the presence of divided right ventricle, which we used to call double-chambered right ventricle. And here you see such an example echocardiographically. You see the narrowing of this ventricular septal defect caused by the parietal band of the crystal ventricular infundibular fold and the septum marginal muscles, the septoparietal muscle here, and here it's formed even a membrane underneath the pulmonary valve. So I think with that, we'll stop this presentation. I've gone a wee bit over time. I want to thank you for your attention, and I'm happy to take and answer any of your questions.
Thank you, Norman. Thank you very much. I cannot say, but I think that both for cardiologist, surgeon who is connected, I think this was an amazing presentation. There are some questions you can check directly if you want in the chat box, in the question and answer.
Yeah, I'm looking to see it now. Let me just, I can't, let me just go full screen.
Yes.
I don't see the stop share. I can't see it.
Oh, you already stopped. You already stopped.
Okay, well, can you read the questions to me?
Of course. How to differentiate between subpulmonary VSD and coronal VSD?
Coronal. I mean, I don't understand the question.
Yes.
Well, you know, look, you doubly committed subarterial VSD, you will always see the membrane of the valve structure as forming the roof of the defect. In a coronal, in a muscular outlet VSD, you will always be able to find a place where there's muscle surrounding the entire defect. And that may be quite difficult because you have to do it in two different or three different planes. And of course, it's very important because many of these muscular VSDs in the outlet septum will close spontaneously. So I think it's important to make this differential. And of course, if you start getting aortic or pulmonary insufficiency, as I've shown in this presentation, it's very, very, very important.
There is a good question. How comes that in Eisenmenger VSD, the anterior deviation of the outlet septum does not produce RVOT obstruction, and in TOF it produces obstruction?
Well, it doesn't ever produce obstruction. And the reason it doesn't produce obstruction is if it produced obstruction, it would be a tetralogy of Fallot. So the deviation of the outlet septum has got to be minimal, okay? And in fact, that specimen that I showed, the example, didn't show much in the way of deviation of the outlet septum. And I think that's the difference. So once you don't see a narrowed outflow tract and you see this deviated out, the superior presentation of the outlet septum, that you're dealing with this Eisenmenger VSD. Now, I can tell you that Eisenmenger VSDs can go on and become blue because of the hypertrophy of the septoparietal and trabeculations and the moderator band, but it's still not tetralogy of Fallot. And of course, there's not much in the way of aortic override in these conditions.
Yes. There is Miguel Arapa. In
Hi,
the
Miguel.
video where he showed multiple muscular VSD in 4-chamber, accelerate flow is seen in the mitral valve with a normal mitral annulus. Does this case have mitral stenosis? I don't know. You show some case probably with mitral stenosis.
No, there was no mitral stenosis. There may be accelerated flow through the mitral valve because you've got a large left to right shunt with increased pulmonary blood flow, and then you'll get a different color because of the velocity across the valve, but it's not mitral stenosis. If we can just talk about this, Miguel, in terms of why we get a mid-diastolic flow rumble in VSDs with a large shunt. And the answer is that we get relative mitral stenosis because we have a mitral annulus with increased blood flow coming from the pulmonary veins across into the left atrium and across the mitral valve. And so it gives rise to the mid-diastolic flow rumble, and that's why the color flow also shows elevation.
Yes.
I hope that makes sense to you, Miguel.
Yes, I hope it will say. You comment, there is a colleague that asked if when there is a VSD associated with PM implantation, they create, they say is like a Gerbode, we can say is a Gerbode defect when the wire of the pacemaker cross the septum.
Yeah. Look, I tell you, I think that it's very common when you see residual VSDs after surgery in the membranous area, because of the surgical technique being so careful to avoid the conducting tissue, you know this better than I do, is that the first stitch goes through the base of the septal leaflet of the tricuspid valve. And if that is not completely closed, then there will be a residual ventricular septal defect with tricuspid regurgitation. And that's what is generally called the secondary type of Gerbode defect. And those are quite common to see TR associated with the VSD. Okay.
Okay. So there are other questions, but I don't think there's because VS Menger. So we did most of the question from the colleague.
Yes. All right. Well, look, I thank you very much for your questions. I think I'll try and answer some of these without you, or if somebody will write to me directly at norm_silverman@mac.com and just place your questions to me. I will give you a full answer on the internet.
Okay. So we wish from Congenital Heart Academy, all people connected and on YouTube, our best Christmas time and Happy New Year. We will see in 2023. Norman, you have to.
I want to say the same, and also to all of my Jewish and Muslim colleagues and all of the people that celebrate Kwanzaa. I wish them the season's greetings as well. Thank you very much.
Thank you, Norman. See you soon.